In November 1999, the Institute of Medicine, now known as the National Academy of Medicine, released its landmark To Err is Human report. The report estimated that as many as 98,000 people died each year in U.S. hospitals because of preventable medical harm. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly, senior writer for AHA. Dr. Jonathan Perlin is president of clinical services and chief medical officer for HCA. In 1999, when the report was released, he worked as chief quality performance officer for the Veterans Health Administration. In this podcast, Nancy Foster, vice president for quality and patient safety at the AHA, discusses the impact that the report has had on the healthcare community.
So, Dr. Perlin, thank you for being with us. As we approach the 20th anniversary of the release of the IOM report, To Err is Human, many are wondering about how things have changed since then. You were leading the Veterans Administration's quality work at the time the report came out. Many seem to be shocked by the report.
So, Nancy, first let me just say thanks to you and to AHA for really taking the lessons of To Err is Human as a guidepost to improvement. We'll have a chance to talk about that, but I remember you and I were both in government at the time, and we'll come back to that point. But yes, I think everyone was shocked by the report. The attention-grabbing headline was that the errors in healthcare equated to the same toll as 3 jumbo jets a week crashing, and that made quite a headline. I was just starting my tenure at VA. I had not become the undersecretary yet, but I was actually a chief quality and performance officer there. And I remember as To Err is Human was about to be released publicly, the chief of staff of the VA came down to my office and said, "Hey, the White House would like some commentary. Would you draft something?" So I went through my notes. I had the privilege of seeing the document in process. And it was amazing to someone relatively new to Washington to hear the words that I had written uttered from the president's lips the next day. If I had known that, I might have written more carefully, but I think he articulated what we all felt, that this really had to be a transition point in the way that we approached the concept of harm and errors in healthcare in terms of understanding how to get behind harm and errors, how to get behind culture, and how to really be more purposeful about achieving safety, reliability, and later with the publication of Crossing the Quality Chasm, a more purposeful commitment to achieving quality.
Excellent. Well, as a leader at the VA, how did this report affect the daily operations and the work you were doing to generate better quality and better safety?
Well, I remember that very clearly as well. The secretary asked, what would be the number one thing that you could do to improve safety and quality and value and the experience of care for veterans? I said, I believe I have 2 answers for you. I said, first, we need to adopt a framework for safety and quality. And second, we need to have full deployment of an electronic health record. And mind you, this was at a time before electronic health records were prominent. In terms of the framework, by definition, Crossing the Quality Chasm hadn't been published. That would have come about 2 years later. But we started with an early framework for thinking about the different dimensions of quality, and ironically focusing more on quality perhaps than safety. And I remember the buckets. There were 6: quality of care, access to care, satisfaction with care, patient functional status, community health, and cost effectiveness. We began to align our measures in these buckets, and that preceded, as I mentioned there, the Quality Chasm report, which introduced us to STEEP: safe, timely, effective, efficient, equitable, and patient-centered. But you get the sense that a framework is very helpful in terms of organizing a more systematic approach to safety and quality. To the second part, the electronic health record, why was I so goal-directed in terms of VA's implementation of electronic health records, something that I would continue working on as the chief operating officer or deputy undersecretary, and continue as the CEO and undersecretary for health. I felt that the electronic health record could really serve as the glue and the fuel. The glue to really tie together care over time across care environments, across the patient's home environment, among the care team members, including the patient, and is the fuel to really mark and measure progress in each of those quality domains. And in that regard, began to think more carefully about measures. And realize this transcends from safety into quality, but we began to think about the different environments of care. What were the needs in preventive services? What were the needs in chronic disease management? What were the needs in palliation? We began to think about different ways of using measures, nested measures or composite measures. So, for example, we knew we had a big audience in Congress. People may not realize it, but if you think you have a complex board, just realize the VA's board is Congress. And so my board was somewhat complex and demanding. And if we wanted to articulate prevention, we weren't going to have sort of molecular conversations of individual measures. They would ask, how's it going? So the prevention index included markers of performance in immunizations, substance use, and cancer screening. And under that, at the level that's needed at the bedside, immunizations, flu and pneumococcal vaccination, substance use, alcohol, tobacco, other substances. Cancer at the time, I believe it was breast cancer, prostate cancer, and colon cancer screening. These measures operated to advance quality. But that's really a sort of 2.5, 3-year picture of response. Going back to where we first met, I remember it galvanized our thinking about a need to partner across government to really accelerate a response. Nancy Foster, that's where I met you, on a cross-agency task force or commission called the QUIC, the Quality Interagency Commission, that was chaired by someone I know you and I both revered, the wonderful John Eisenberg, who really, through the QUIC, indelled the concept of building safety and ultimately quality into the framework for thinking about healthcare in the United States, certainly at the federal level.
Excellent. It's amazing to me how your early work at the VA to create buckets, to identify a structure for thinking about quality has really transformed thinking across the entire enterprise. So you're now the Chief Medical Officer for another large system, HCA, and you're a nationally renowned leader in quality. From this vantage point, do you believe there has been improvement in safety over the past 20 years? And can you give some examples of what you've seen?
Well, thanks, Nancy. First, I'm an optimist. So while we have work to do, recognizing that the only right amount of preventable harm is 0, I believe we've made progress. Most importantly, we no longer view failures as just bad luck. When I trained, central line infections, for example, were thought to be unavoidable, were thought to be just bad luck. Of course, today, with the accumulation of evidence, we know that there are ways to reduce the likelihood of a central line associated bloodstream infection, so we don't say that's bad luck. We go back and try to understand what could have led to a more reliable avoidance of infection. I think we have good data that have shown that while we still have work to do, healthcare-associated infections and central line infections have decreased. Second, we think about a culture of safety as a prerequisite for a high reliability organization or endeavor or field. And third, we really do have measurable progress. I alluded to that on healthcare-associated infections in the area of childbirth. We talked earlier today about the importance of studies like 39 weeks that showed that avoiding early elective delivery reduced the unnecessary utilization of newborn intensive care, the unintentional but avoidable harm to newborns and, frankly, families as well as the economy. We've seen progress in areas like immunization, and so I think that while there are still many challenges that persist, we've made good progress. I think I want to make another point, which is that I've sort of flipped back and forth between safety and quality. And while purists may view safety as the avoidance of harm, it's hard to disentangle what may really be two sides of the same coin. So we've also made progress in areas like the treatment of coronary artery disease, certain processes of care around that, the administration of lipids, the reduction of tobacco use, ditto, and hypertension. In stroke, we've made progress in terms of processes of care like door-to-needle time, and these have saved lives. They've made measurable improvements in mortality. And so I think we have to recognize that while harm can accrue, if you will, from errors of commission, not washing your hands, avoidable hospital-associated infection, harm can also accrue from errors of omission. And so I think it's helpful to think both about safety and quality simultaneously. And then finally, I think in addition to progress we've made in terms of creating a field of safety and quality where we've transcended a notion that it's just bad luck, the progress that we've made in terms of thinking about a culture of safety that makes this other work possible. Third, the measurement that we partake in both safety and quality, that there are roles for forcing functions or technologies that help to support us becoming more reliable. And both at VA and at HCA, we've used technologies a great deal. One of the areas I'm most proud of that was really inspired early on by the safety movement was the area of barcode and medication administration. I remember this story exceptionally well because the two organizations I've been associated with were really at the forefront of initiating barcode and medication administration. Sue Kinnick, now deceased, a wonderful nurse in the VA system, returned a car in Seattle, Washington, and began to cry. And it wasn't that she missed her car. The reason was far more somber, is that she was charge nurse on a unit that had a patient death from a drug error. And she watched the car be checked in by a rental agent who checked it in with a barcode and said, I've got an idea. What if we had barcode for secure administration of medications, making sure that the patient gets to enjoy the right medication, the right dose by the right route at the right time? Wouldn't that work? And she brought that idea back. And some of the VA technology folk, the programmers, got together and said, I think we can do this. And it was implemented. And I arrived at HCA and found out that my colleague Jane Engelbright, now the chief nursing executive, was leading an effort along the same lines. And so we've made great progress as well in technology that helps us fly this jumbo jet of healthcare more safely.
Well, thank you for that story. I had never heard that before. And it reminds us that every one of us has an opportunity to contribute by bringing a new idea to the table about how to make safety more relevant and more doable in every one of our organizations. Could you tell us what are those most important lessons you think we've learned over the last 20 years about how to improve safety, or more broadly, quality?
Yeah. Well, I think it starts with a worldview, which means that safety is really a property of culture. And culture is a property of transmitted values. So creating a safe space for safety, a culture of safety, is incredibly important. So Jim Bajan tells the story of a young seaman on the deck of an aircraft carrier. He thought he might have dropped a wrench. Now, a wrench could be extremely devastating if it got sucked up into the air intake of a jet on takeoff. It could be catastrophic. And he told his superior absolutely the right thing. And the superior told his superior, and somehow it got up to the commander of the ship. The commander said, let's have a stand down. Stop all functions. Get that young seaman to my office. I want an all-hands meeting on deck in exactly 1 hour. As you might imagine, this young seaman was quaking in his boots. And instead of chewing them out as the young seaman expected, the commander of this aircraft carrier turned to all and said, I want you to understand what courage it took to stop the line. Had he not done this, and had that wrench not been located, we might be at a loss for one or more of our colleagues right at this very moment. That took courage. That's the right thing. It's what I want us to do. That lesson wasn't lost on me. When I had the privilege of becoming undersecretary, I became aware of a misadventure in Northern California with the sterilization of endoscopy equipment. And a young tech thought that the equipment might not have been put together as tightly as it might. This may sound a little abstract, but it turns out there's a different maker of cleaning solution, different maker of the sterilization apparatus, the tubing, and the different maker of the scopes itself. And no one could verify that it was adequately sterilized. And as my first official action as the new Undersecretary and CEO, we did an all-hands call where I had the opportunity to thank this individual for the courage of coming forward. I think one of the things we see is that these are no longer isolated actions. I think we see healthcare leaders really asking their teams to stop the presses when there's a problem, that everyone's empowered. That, to me, is one of the most important lessons of the last 20 years. I think now that we recognize safety and quality as clinical disciplines in their own right, with tools from productions and systems engineering to epidemiology, but those are all incredibly important tools that only work in the right cultural context. So to me, that's the lesson number one of the past 20 years.
That's an incredibly important lesson. And yes, Jim Bajan has taught us a lot about patient safety. You are also a noted leader in the use of information technology, and you talked about this a minute ago in your ongoing role in advancing information technology. Say a bit more, would you, about the role information technology can play in patient safety?
Yeah, well, information technology are probably among the most important tools in terms of the safety systems we need to improve the reliability of care. We've been using a lot of aviation metaphors here, so I'll continue on. We need to have information, the right information, available at the moment a decision is being made. And we wouldn't dream of flying a plane without decision support. In fact, today's fighter planes won't fly without computer-aided assistants that can react faster than humans can. And in a sense, we're waiting for the payback for the pain of implementing electronic health records. Well, ladies and gentlemen, here it is. The digital dividend is all of the information that has accrued. We need to make use of that information from electronic health records. Let me give you an example of that digital dividend, that payback that makes the challenge of electronic health records worthwhile. The area of sepsis, leading cause of death. In non-cardiac ICUs, the number one cause of death, and according to a recent study, 35% of all deaths in American hospitals are ultimately coded out as sepsis. Overwhelming infection, or more importantly, the body's response to an overwhelming infection in a vulnerable situation. Older individuals, children, individuals with chronic illness. Over the last few years, there's been a lot of progress made in surviving sepsis. In fact, the Surviving Sepsis campaign really gained traction in about 2013 following the death of Rory Stanton, a 12-year-old in New York City who presented twice to care providers and sepsis wasn't recognized. And his parents, after his tragic loss, became quite effective activists. They got Rory's laws passed in New York State that really required hospitals to understand the signs of sepsis. And in a sense, the Surviving Sepsis Toolkit recognized that certain features of sepsis needed to be responded to urgently. But here's the problem with sepsis. Every hour of delayed diagnosis increases the risk of mortality by up to 8%. So by the time you get to these late features of sepsis, it's fighting severe sepsis by definition. Or to use a fire analogy, it's fighting a severe fire. Here we are in Washington, D.C. The analog would be the Washington Fighting Severe Fire program is that we respond when the flame's shooting out of the building. We asked the question at HCA Healthcare whether we could develop a smoke detector, in this instance, a sepsis detector. And we named it Spot after every little kid's dog that sniffs out things, but SOT actually stands for Sepsis Prediction and Optimization of Therapy. And using the commonly collected data from electronic health records in conjunction with real-time vital signs, demographic information, lab information, pharmacy information, we actually now have a sepsis alert. So we started with the workflow. Between 2013 and 2017, we actually improved survival in sepsis on septic shock by 39%. Terrific. 10% improvement on average every year, even to benchmark levels of survival. But when we superimposed the sepsis smoke detector Spot, year over year, 2018 over 2017, we got a 23% improvement. turns out what we can do is actually allow the clinician to do something they can't humanly do. Be simultaneously at the bedside caring for patients, but simultaneously scouring every last piece of data until the features of sepsis are present. And as soon as the computer sees these features of sepsis, it presents those features to the clinician. They said, yep, that's sepsis. Let's start an intervention. So the computer's not making the diagnosis, but it's showing the clinicians the features of the diagnosis. And year over year, we more than doubled the rate of improvement in survival. To me, the magic's this. One, that it's what you or I would want if our loved one's in the hospital. That the care team member is both hanging on every piece of data and at the bedside. Two, that they're presented with knowledge as a job aid to improve their performance. That is, here are the features of sepsis, here's what your patient has. And three, that there is a very well-elaborated, well-practiced workflow, courtesy of the Stanton's activism, the Surviving Sepsis Toolkit. And fourth, that here is a trigger that buys you 8 hours earlier lead time for a condition where survival improves. Again, 8% every hour of earlier detection. And for me, the final proof point is that over the course of the improvements using the Surviving Sepsis Toolkit and SPOT, we've saved 8,000 lives. Lives of 8,000 individuals who live to see in a new year, welcome a grandchild, celebrate an anniversary. And to me, that takes you back to the why that I think is at the heart of empowering a culture of safety.
What a spectacular example of the use of information technology to support and drive the kind of care that clinicians want to be providing in a safe and simple way. And not that anything in medicine is simple these days, but getting that support at the right time is really effective. That's impressive. As you look forward to the next decade of progress in healthcare, what do you see as the most important opportunities for hospitals and health systems to do in improving patient safety?
Well, after our discussion about sepsis and the use of the sepsis detector, you'll probably not be shocked that I think the greatest opportunity is really in harnessing that data, that payback for the use of electronic health records, that digital dividend that drives data availability, data liquidity, and the use of artificial intelligence. We need to be a learning health system. 2007, following To Err is Human, Crossing the Quality Chasm, the Institute of Medicine, I think, came up with a concept that really empowers the notion of improvement at its best. That a learning health system is one that operates with a virtuous cycle of data being generated inevitably as a byproduct of care, being captured in such a way that can be channeled back into the care of that patient, subsequent patients, and the improvement of the system itself. Improvements in safety, quality, efficiency, experience, every dimension, and as a vehicle for discovery. And so if you start with this notion of a learning health system, a virtuous cycle, where the data aren't extinguished at the point a transaction is completed, yep, I got the blood test, but rather feed into a collective memory, you can really see that we'll drive ourselves up the analytic hierarchy and accelerate improvement. We'll be able to move from descriptive, what happened, X number of patients had sepsis, diagnostic, why did it happen? Oh, here's a culture that's positive for MRSA, to predictive, cultures aren't back, but this patient's blood pressure is decreasing, the heart rate's increasing, which is predictive, what will happen, to prescriptive, what should happen. And taken to its ultimate form, we move beyond the sepsis detection to the prediction, and the computer helps us see these signals before we recognize them, even perhaps before there's the full spectrum of signs that equate to sepsis. And that's the point at which we intervene and make the patient care even more reliable, even safer, even more effective. Now, the ultimate expression of this hierarchy from descriptive to diagnostic to predictive to prescriptive is autonomous. And while you might think that we're not quite ready for the self-driving hospital, the truth is there are actually autonomous systems in healthcare, robotics. So, for example, the lasers that ophthalmologists use for eye surgery actually have a response that the computer generates when the patient blinks, so that the laser is not inadvertently applied to the eyelid. And these are the sorts of support tools that will become more commonplace in flying and driving the hospital of the future. And what's really cool about these data sets is that I know we've tended to think of the depth of data as in hospitals, and certainly we have opportunity there. But what's really exciting is that the future data really combines that with health indicators, social determinants of health indicators, data from not only traditional settings but non-traditional settings, patient-reported outcomes, and allow us to really address not only the end stages of disease but the root causes of disease. And I think these are exciting opportunities for the next decade to 20 years.
That is very exciting, and sort of takes us from your smoke detector analogy to identifying where there's a match and flammable material and someone willing to set off a spark, and to really move us upstream. If there was one thing you could do or change about policy or hospital strategy that you think would really accelerate enhancements to safety, what might it be?
Well, Nancy, you probably know the answer, and some may be surprised by the answer because it's not highfalutin or highly technical. It would be all about washing your hands. Hand hygiene shouldn't be more reliable in a cruise ship buffet than it is in a hospital. And not washing hands is not only disrespectful for patients, and we know that healthcare-associated infections are unsatisfying to patients, providers alike, but we're supposed to be agents of health, not vectors of disease. Which reminds me, as we approach this time of year, that we need to remind ourselves to get vaccines for the number one vaccine preventable cause of death, and that is influenza. So notwithstanding the influenza vaccine, the flu vaccine plug, if we wash our hands and get vaccines, then we live up to the prime directive of healthcare, which really is the point of To Err is Human, first do no harm.
Thank you very much, Dr. Perlin. This has been great. I know our audience will very much appreciate it.
Well, Nancy, thank you for the opportunity. Thanks to all of our healthcare colleagues who've really not only been inspired by To Err is Human, thanks to the American Hospital Association for really helping to give that traction. And I think both of us owe this report the opportunity to meet early and also reflect on the debt of gratitude we owe to someone who is mentor, scholar, and inspirational in this area, the late John Eisenberg.
Agree completely. Thank you.
Thanks.